This is CCTA case number 29. The history is that of a 49-year-old man with persistent exertional chest pain despite a normal exercise stress test. There are two major phases for review in this study, and they can be changed by moving the cine control back and forth, forward and backward. Now, this is a very difficult case and not atypical for many of the kinds of scans that you'll be asked to review. We're going to focus first of all on the left main and the circumflex, and then we'll go to the other vessels. The left main itself appears to be normal. I can switch to another phase. I think this is basically the better phase here, and this appears to be essentially normal. Let's start looking at the circumflex. It comes off a bit more distally here. As we move down, we're going to rotate around the circumflex, and we can see that there's a portion of the obtuse marginal here that has some questionable lesion. Let's focus down in that region. We can see the actual remainder of the circumflex coming around very nicely. This appears to be normal. This is a dominant vessel. As we go down a little bit further and put it in a foot view, we can see then the distal distribution of this vessel and a very small PVA. But let's return back to the other question that we had just a little bit previous to this, which is looking at the obtuse marginal. So here we are at the obtuse marginal, and this vessel appears to have clearly obstructive disease right at the ostium of the obtuse marginal, with what appears to be probably non-calcified, possibly mixed plaque, followed by some calcified plaque just distal to that, and then relatively good distal opacification. Again, as I've said in the past, we cannot evaluate antegrade versus retrograde flow on cardiac CT, but this is either a totally occluded vessel or a subtotally occluded vessel. So we've already proven the point in this patient that he has obstructive disease and that further evaluation is necessary. But let's look at the other coronary vessels. Let's start out here looking at the left main. I've got the proximal segment here in the crosshairs. You'll notice there's a little fuzziness, if you will, a little bit of just irregularity in the proximal LAD, and I'm going to rotate around just a little bit here, and I believe I see probably some non-calcified plaque, but it is not obstructive in the proximal left anterior descending. Let's proceed down a little bit further. Here we see clear mixed non-calcified and calcified plaque involving the mid portion of the left anterior descending. Change to the other phase to see if that helps. It really didn't help. So this appears to be the better evaluation. So even though this is a relatively long lesion, it appears to be non-obstructive. Now, one of the measures that we commonly will look at is that to help determine overall potential for obstructions, you want to look at lesion length. So I'm going to go and measure approximate length of the lesion as best I can, going basically from here to here. So I'm getting about 10 millimeter lesion length. That increases the potential for this to be hemodynamically significant, even though it's unclear. So this is something that would need to be further evaluated. On baseline, it appears to be non-obstructive, but it is a long lesion. Let's finally look at the right coronary artery, returning to the foot view, beginning in the proximal right coronary. Let's switch to another phase. This phase may or may not be a little bit better. There's some fuzziness also in the proximal portion of this vessel. There are some areas here that are not particularly well seen. There may or may not be some plaque in there. I'm not convinced that there's any clear obstructive lesion. There clearly is a fuzzy area right here, which is probably more of a motion artifact. Again, switching to another phase doesn't seem to really help, and then we can see the vessel proceeding down to the distal aspects and then down to the distal portion of this vessel. There's an acute marginal coming across, which also helps supply a portion of the inferior septum. So in summary, in this 49-year-old man who has exertional chest pain, although he had a normal stress test, we found clearly obstructive disease in the first OM. We found borderline obstructive disease just because of length in a mixed calcified, non-calcified situation in the mid-LAD, and we have a right coronary that's quite not satisfactorily evaluated. So given the fact that this patient has had a stress test, I would urge that this patient would be appropriate to have coronary angiography, and then a further definition of these areas, and perhaps a focal intervention such as an angioplasty or stent placement.